Welcome to the webinar.
Good day. I'm Judith Currier from University of California in Los Angeles, and welcome you all to this webinar. While we're waiting for people to enter, please fill out the demographic questions that are in the pop-up screen. This is really helpful to us. I am thrilled to be joined today by Dr. Jason Zucker from Columbia University. He's an assistant professor there and has really been on the front lines of Mpox clinical care, treatment, as well as research. And he's backed by popular demand to provide us with an update. And I know Jason has been updating the material in his talk as recently as probably yesterday, given that new information about Mpox is coming at us fast and furiously. And I think this is a great time to just step back and learn what's happened recently and how we're approaching this new infection. So I'm going to turn it over to Jason to take us through updates on, actually we have a few slides first, excuse me. The first one is the disclosures for the content on the web board. Those are listed here. And next are the disclosures of the presenter, moderator, and peer reviewers are listed here. The IAS-USA designates this live activity for a maximum of 1.25 CMV credits. The webinar is also approved for 1.25 hours of ABIM mock points and nursing, pharmacy, and pharmacotherapy credits. Generous support for this activity has been received from the following contributors. This on-demand recording and slides will be available within 24 hours, so you'll be able to come back and listen again or share with your colleagues. And then finally, during the webinar, do use the Q&A to submit questions. We've set aside time at the end for 10 to 15 minutes of Q&A, so don't put them in the chat, put them in the Q&A. All right, now back to turning it over to Jason to provide us with this update on the global Mpox public health emergency. Jason, thank you.
All right. Good morning, everybody, and thank you again for joining me, and thank you for the introduction. These are my financial disclosures and the learning objectives for today. First, we'll discuss and describe what we knew about Mpox before the 2022 outbreak. Next, we'll look at what's been learned about testing, treatment, and vaccination since the 2022 clade 2B outbreak started. We'll talk about some similarities and differences between clade 2 and clade 1, which has been responsible for the newly called public health emergency of international concern. And we'll summarize what is still unknown and what is needed to address these knowledge gaps. With that, we'll have our first pre-test. And as a reminder, we'll be diving into these updates and covering this information over the course of today's webinar, and you'll get these questions again at the end. So our first one was just about sort of how many patients with Mpox have you diagnosed since the start of the outbreak? And it's interesting to watch this number creep up, as this is the third time we're doing this. We're down to only 44% of people not having diagnosed a single person, and 10% of people having diagnosed more than 10 people with Mpox. And those numbers have really been changing over the course of the last 2 years. Next is the first pretest question. Which of the following antiviral treatments has been shown to be effective against Mpox in humans in a randomized clinical trial? And as I mentioned, we'll cover this over the course of today. And question number 2, which of the following groups is recommended to receive Mpox vaccination by the Advisory Committee on Immunization Practices, or ACIP? All right. So to get us started, we've learned a lot since the outbreak started in 2022. And these are the PubMed articles for Mpox or monkeypox over time. And as you can see, the scientific knowledge has expanded rapidly over the last couple of years. From 1962 to 2002, we only saw about 186 total publications. From 2003 to 2021, 689 or 36 per year. And then in just the last 2+ years, there have been over 4,500 publications, or almost 135 per month, more than we had in almost 40 years previously. This surge in research really reflects the global response to the Mpox outbreaks. But it is essential to note that a lot of this research has been focused on clade 2b, with only a small portion really addressing clade 1. This emphasis can leave us with gaps in our understanding of clade 1, which can pose challenges down the line. And today we'll talk a lot about what we've learned from all of this work, as well as what we still need to know. So we'll start by talking about what we've learned about epidemiology and transmission. The global landscape of Mpox changed rapidly starting in 2022. Earlier we thought about Mpox being a double-stranded DNA virus with 2 clades, with limited geographic spread, and primarily zoonotic spread with limited human-to-human spread, primarily within households. Since that time, we've learned a lot more. There have now been over almost 100,000 cases of clade 2 since the start of the outbreak, affecting 122 countries, including 115 previously non-endemic countries. In response to the rapid worldwide spread of Mpox, the WHO first declared a public health emergency of international concern, or PHEIC, in July 23rd of 2022. This marked really a significant step, signaling the urgency of an international and global response to the outbreak. Nearly 10 months later, the WHO ended the PHEIC on May 11, 2023, at which point case numbers had declined and stabilized the outbreak spread. The United States was heavily impacted during the 2022 Mpox clade 2 outbreak, contributing nearly 34,000 cases. But what you can see from this epi curve is that it really surged in the summer and fall of 2022, reaching a peak of over 3,200 cases per week, followed by a rapid decline. Although cases dropped significantly, they never fully disappeared, and weekly case counts never went to 0, and there was ongoing low-level transmission continuing. I want to make a note and highlight the relatively stable epi curve since October of 2023, with around 56 cases per month, or a little over 56 cases per week, and a little over 200 cases per month over the past year. And this ongoing low-level transmission is one of the reasons we're here today to talk about this. It really highlights the need for continued vigilance, surveillance, diagnosis, and the ability to care for patients who may still acquire Mpox. The other thing going on is another big reason why we're here today. And that's that while the 2022 Mpox outbreak was slowing, there was another parallel outbreak going on of clade 1 Mpox in the Democratic Republic of the Congo. As you can see from this epi curve, unlike in the United States where cases stabilize, the case count in the DRC remains persistently high, fluctuating between 300 and 400 cases per day on average. And I did this slide a week ago, and the numbers have already increased since then. But since January 2024, there were almost 40,000 suspected cases, with about a 2.7% case fatality rate. Of those, over 8,600 have been lab confirmed, with a case fatality rate of 0.48%. As cases have increased, we're also observing a genetic divergence within clade 1 Mpox. Clade 1A often represents the classic Mpox, primarily spread zoonotically and within households, with a high proportion of pediatric cases. In contrast, clade 2B emerged with evidence of sustained human-to-human transmission, potentially driven in part by sexual transmission. The shift in transmission dynamics really highlights the evolving nature of the outbreak, underscoring the need for targeted interventions and addressing both clade 1 and clade 2 Mpox. The spread of clade 1 Mpox was not limited to just the DRC. It began to expand outside, including into nearby countries. leading the WHO to declare a second public health emergency of international concern on August 14th of this year, really reflecting the global concern about clade 1's potential for sustained human-to-human transmission and geographic expansion. The emergence of clade 1 has really led to heightened concern, and as we can see here, media coverage has captured a sense of urgency, fear, and even panic. But as we'll see, much of this may be overblown. Where are we now? Well, today we recognize 4 distinct clades of Mpox, each with varying geographic distributions, modes of transmission, and potential disease severity. Despite these differences, the clades do share common features in how they transmit, treatment options, and preventive strategies. I highlight this because as we go through today, I'll make sure to highlight any key differences between clades where applicable. This graph on the bottom right shows Mpox's global spread. The green areas representing clade 1A, the blue areas representing clade 1B, and notably clade 1B has expanded beyond its usual range, with cases now reported in India, Thailand, Sweden, and most recently indicated by this blue star here, England, with 4 confirmed cases. Again, highlighting the fact that we're now seeing it outside of the DRC and the need for expanded surveillance around the world. Now that we've covered a lot on epidemiology, I want to talk about what we've learned about Mpox transmission. Whenever I talk about transmission, especially here in New York, I often get questions like, can I get Mpox on the bus or subway, on the grocery store, at the clothing store, gym, salon, or even classroom? These are all places people visit frequently, so it's a natural concern. And the answer is probably not. Mpox transmission generally requires close, prolonged contact, so these everyday activities are generally low risk. There are 3 primary modes we think about when thinking about Mpox transmission: direct contact with infectious lesions or body fluids, contaminated fomites, and respiratory secretions. It's clear that most cases in this outbreak have been caused primarily by close physical contact with infected lesions or body fluids, whether that's either from animal hosts, particularly in clade 1A, or from human-to-human transmission in many of the other transmission pathways. We know that fomites, particularly soft, porous items like linen and sheets, can transmit the virus, and there are reported cases. This has not appeared to be a major driver of the current outbreak. Finally, there is a thought that contact with respiratory secretions can be a route of transmission, but it likely requires prolonged face-to-face exposure, and a recent systematic review by the CDC did not find any sustained outbreaks from contact with respiratory secretions. As just a reminder to providers, due to these different potential routes of transmission, the CDC does continue to recommend specific infection prevention and control measures for evaluating patients with suspected Mpox. This includes a gown, gloves, eye protection, and an N95 respirator. Fortunately, transmission to healthcare workers has been exceedingly rare, reinforcing the effectiveness of these precautions. Most healthcare worker exposures or infections have actually been from needle stick injuries, reminding us that we're not supposed to unroof lesions when we're testing, and we'll talk about that a little bit later. Another important insight that we've learned is that both pre-symptomatic viral detection and pre-symptomatic transmission can occur. This was a prospective cohort study where viral DNA was detected in 5 of 6 participants, 1 to 4 days before they showed any symptoms. Additionally, in this other study, through contact tracing, researchers were able to identify pre-symptomatic transmission in 5 of 18 pairs. So again, while transmission is primarily through close physical contact, it can occur in the pre-symptomatic phase before people even know they're infected. And this aligns with what we know about outbreak management and sort of makes sense when we think about how quickly this spread, especially because pre-symptomatic individuals could potentially unknowingly transmit to close contacts. So we talked about pre-symptomatic Mpox, but what about asymptomatic cases? So on the left was a study from Belgium, where researchers screened 224 samples for gonorrhea that were collected for gonorrhea and chlamydia testing. They found that 3 rectal swabs and 1 pooled sample were positive for Mpox. Notably, 3 of those 4 individuals never developed any symptoms, suggesting the presence of asymptomatic cases. And even more significantly, all 3 asymptomatic individuals had positive serology, and 2 had culturable virus, really suggesting the potential for transmission even without symptoms. This finding is further supported by a serology study conducted in New York City, which was done before vaccination was available. And it suggested that 1 in 15 vaccine-naive individuals had antibodies to Mpox during the peak of the New York City outbreak. Again, the presence of asymptomatic infections could contribute to the ongoing transmission that we see. And more research is needed to really understand the implications of this. So we really have learned a lot. We learned that Mpox demonstrated the potential for rapid worldwide spread. It was primarily driven by human to human transmission, likely facilitated by sexual networks, seen in both clade 2b and now being seen in clade 1b as well. Respiratory transmission, which was initially a concern, now appears to be an unlikely mode of spread. And importantly, both pre-symptomatic and asymptomatic transmission are possible, which may in some ways help explain the outbreak's rapid spread and reinforces the need for thorough testing and contact tracing. But despite what we learned, there still are many unanswered questions. For instance, are there differences in transmissibility by clade? There are some theories that clade 1 may be more transmissible than clade 2, but they've happened in different populations, and so understanding if this is a genetic difference or a population or network difference is important. Are some routes more efficient for transmission? Is that why we saw more transmission among sexual contacts, or is it simply the close physical contact that occurs during sexual contact? And how can we further prevent Mpox transmission? And that's something we'll talk about a little bit later. So now we'll shift our focus to the presentation and pathogenesis of disease. Before 2022, our understanding of Mpox was based on established patterns from previous outbreaks. Mpox typically followed a predictable course, a prodrome of fever, malaise, and other early symptoms like lymphadenopathy, followed by a rash that progressed synchronously. In terms of severity, we thought that clade 1 had a fatality rate of around 5%, and clade 2 with a lower mortality rate of around 1%. We also understood that certain populations faced worse outcomes, particularly pediatric and pregnant patients who are at higher risk of severe complications. So we'll start by talking about how Mpox presents. This is the classic presentation of what we'd expect to see with clade 1. After the incubation period of 2 to 21 days, but a median of about 7 days, Mpox presents with a viral prodrome similar to many other illnesses. Fever, lymphadenopathy, myalgias, malaise, headache were all common. After the prodrome, patients usually develop a rash. Classically, it starts on the face and spreads to the extremities, including the palms and soles, and will progress through several synchronized stages that can be extremely painful and last up to 4 weeks. The rash usually occurs before day 5 and most commonly on days 1 to 3, and is described as well circumscribed, deep-seated, sometimes umbilicated, which are classic lesions for this disease. And you can see the photos here. We have the regression. We don't have photos of the macules, but of the papules, vesicles, pustules, including umbilicated pustules, scabs, and patients are not considered no longer contagious until the scab has fallen off with clean skin underneath or reepithelialization. However, during the 2022 Mpox outbreaks, we saw disease presenting very different from the classic pattern. The rash may often appear before or after the prodrome, was accompanied by asynchronous lesions, which could be in multiple stages on the same body parts. We saw high rates of genital, anal, urethral, and pharyngeal lesions, often linked to sexual transmission, and often as frequently the presenting symptom, even before a visual rash. Ocular Mpox from direct inoculation or autoinoculation pose sight-threatening risks to patients. Lymphadenopathy near the lesion sites and bacterial superinfections further complicated recovery. I like to highlight this because given these atypical presentations, a high index of suspicion really is crucial to ensure that cases are not missed. I also want to take a moment to discuss severe Mpox. While Mpox can be serious, it's important to note that the mortality has been much lower than expected, about 0.17 to 0.18% in the United States, with 60 deaths out of almost 34,000 cases. However, most cases of severe disease and nearly all deaths have occurred in people who are immunocompromised, especially those with advanced HIV and low CD4 counts. This chart on the right really highlights the stark difference in persons with CD4 counts below 100, the orange line, who have significantly more complications in all systems than those with higher CD4 counts, shown in the purple, blue, and green lines. In short, Mpox behaves like an opportunistic infection, really exploiting persons who have weakened immune systems. Returning to clade 1, while it's been observed to cause more severe infections, the death rate among confirmed cases has been lower than expected, and the case fatality rate has actually decreased as cases have increased. It really remains unclear if and by how much clade 1 is more transmissible and more severe than clade 2. So why do some patients experience severe Mpox? I think understanding the pathology does provide us some insight. This study looked at prolonged Mpox cases in people with advanced HIV who were not on antiretroviral therapy. Immunofluorescence of skin biopsies showed a dense immune infiltrate, which you can see really nicely here. While RNAscope detected extensive Mpox viral replication in epithelial and dendritic cells. And it really suggested that with this ongoing Mpox replication, it really warranted aggressive medical countermeasures and immune optimization. And it's not just the skin that we need to worry about. Mpox can affect more than just the skin. The Mpox Pathology Working Group analyzed biopsy and autopsy tissues from 22 patients with severe or fatal Mpox, and they identified extensive viral infection and dissemination across tissues. Extensive dissemination that progressed even with available treatments. In these images, you can see viral presence in the lung, lymph node, spleen, liver, and adrenal gland, really demonstrating the widespread tissue involvement. Of note, the digestive tract and lung were particularly common among these patients. And so again, for patients who are immunocompromised, we really do see widespread dissemination of disease with ongoing replication, explaining the severity and high mortality rate. As a med-peds physician, I was actually initially very concerned about how Mpox would affect pediatric patients given the prior data. In the 1980s, data from Africa suggested higher severity and mortality in children under 8, with the youngest at greatest risk. Additionally, during a 2003 Mpox outbreak linked to prairie dogs, about a third of cases were pediatric, and those patients were more likely to need ICU level of care. Thankfully, this outbreak has shown much more reassuring outcomes. The data from this outbreak so far indicate no pediatric deaths and a relatively low hospitalization rate, suggesting that it may not be that much more severe than it is in our adult patients. However, that's not true for all patients. Data on Mpox in pregnancy has been limited, but what we've seen has been concerning. Initially, we had reports of 5 cases, 3 of which ended in fetal loss, with Mpox detected both in fetal tissue and placenta. This raised a lot of concerns and alarm, as smallpox is also known to be more severe during pregnancy. Over the course of this outbreak, data has been sparse. In 2022, the CDC reported 23 cases in pregnant or recently pregnant individuals, 4 requiring hospitalization, and 11 receiving tecovirimat without adverse effects. However, we don't have a lot of outcome data yet. Published outcomes include 2 uncomplicated deliveries and 1 spontaneous abortion. The WHO has documented 54 cases, but outcome data is still lacking, and we know of at least 1 case of vertical transmission. Some of the studies we've seen have suggested a 33 to 50% fetal death rate, along with the potential vertical transmission, particularly with later stage infection. However, these really are small observational studies, which highlight the need for more comprehensive data to better understand the risks and guide our clinical management of our pregnant patients. Up until now, we've mainly discussed the short-term acute impact of Mpox. However, many of my patients are often most concerned about the long-term effects. And this is where the CDC's Life After Mpox or LAMP study comes in. LAMP evaluated patients 10 to 18 months after acute infection. They found that more than half of participants reported at least one persistent sequelae, impacting their appearance or function. And you can see on the right-hand side the rates of persistent sequelae. Very common for non-mucosal sites, 56%, only 9% at mucosal sites. Very common to be face and ears, as well as groin and pelvis. Additionally, the study highlighted the significant and ongoing stigma associated with Mpox. You see here, 30% were hurt by how people reacted to their Mpox diagnosis. 22% still felt that people were hesitant to be around them since their Mpox diagnosis. 18% lost a job or income due to their Mpox diagnosis. And 18% still felt that they had changes in their looks or appearance since their Mpox diagnosis. And again, this really highlights the need for interventions to reduce the psychosocial impact and address future vulnerabilities relating to Mpox. Because as a reminder, Mpox cases are still occurring every single month. So since the outbreak began, we've learned that most patients recover. Presentations can be highly variable, but can also have the involvement of mucous membranes. Immunocompromised patients or patients who are immunocompromised have the potential for a severe necrotizing disease with viremia and high rates of morbidity and mortality, and pediatric patients without notably worse outcomes. Some of the questions that are really still outstanding: does Mpox lead to IRIS in persons with HIV and low CD4 counts? We didn't really get into that here, but we do see these high rates of patients, high rates of mortality among patients who are severely immunocompromised. And what role does IRIS play in that? I think it's pretty obvious that we need to put them back on antiretroviral therapy to improve their immune system, but do we also need to be more aware and manage IRIS as well? The second point is, what is the impact of Mpox on pregnant persons and their fetuses? And how does that change our thoughts around management and prevention? So we've covered epidemiology, presentations, and pathogenesis. Let's briefly discuss diagnostics and how to make the diagnosis. This will be a relatively short section, as this has not changed dramatically over the course of this outbreak. When the outbreak started, we had orthopoxvirus PCRs available only at lab response network labs and only to be run on lesional swabs. However, testing was quickly scaled up in commercial labs, increasing testing capacity dramatically. At the same time, we also learned that Mpox DNA could be found in seminal fluid, rectal swabs, urethral swabs, respiratory secretions, blood, and other body fluids, which naturally brings up the question, are skin lesions the best place to be testing? And the answer is probably yes, even though the virus can be detected in multiple sites. This study used CT values as a measure of viral load and found that skin lesions have the highest likely viral load, or lowest CT value, followed by rectal swabs, throat, blood, urine, and semen. However, skin lesions not only have the highest viral loads, they also persist the longest, with viral loads in blood, semen, rectum, and pharynx clearing over a week faster than those in skin lesions. In fact, skin lesions maintained a median viral load at least 3 logs higher than other samples. So given their easy access and high visibility, high viral loads, and viral persistence, skin lesions continue to make sense as the primary site for Mpox testing. However, one thing I will note is that because lesions may appear only after symptoms like pharyngitis or proctitis, the diagnosis could be delayed if we only have skin lesions to test from. Currently, however, most Mpox diagnoses are made via PCR of lesional swabs. These are available through local, commercial, and public health labs, many of which have emergency use authorization. While commercial EUA test kits are limited to lesional swabs, some academic centers have validated testing of other sample types and other physical body sites. Additionally, I just want to highlight that one commercial lab has obtained approval for home specimen collection, which is really a great option to have and may help overcome stigma and enable more people to be tested and diagnosed. Lab tests for Mpox vary. Some target only the orthopoxvirus target, while others can specifically detect both orthopoxvirus and a clade 2 target. We talked a lot about clade 1 at the start of this, and clade-specific testing is recommended for travelers returning from regions with active outbreaks, or for individuals exposed to someone from those regions. It's also advised if the orthopox test is positive, but the clade 2 target is negative. And I will highlight the fact that while surveillance is ongoing, as of at least yesterday, no clade 1 cases have been reported in the United States. So we learned that orthopox virus testing from skin lesions could be scaled up quickly at commercial labs, that Mpox virus could be identified at many different body sites, and that skin lesions remain the only site widely approved for testing. In this section, it's less about what we need to learn and more about what we need to develop. We need validated commercially available tests for other body compartments, along with a multiplex lesion PCR. I mentioned earlier that for Mpox, a high index of suspicion is critical. A multiplex PCR that includes other potential diagnoses like HSV and syphilis would be incredibly useful. This is probably more important now than ever, especially as cases are lower and Mpox might not be on the top of the differential in settings like the emergency department or urgent care. Now that we've covered diagnosing Mpox, let's move on to managing it once the diagnosis is confirmed. Before 2022, we had preliminary and in vitro data on a lot of potential therapeutic options. Tecovirimat had been approved for smallpox via the animal rule and was available through an EA or expanded access IND, but there were concerns about low barriers to resistance. Brincidofovir was also approved for smallpox via the animal rule and was available through an EIND, and there was in vitro synergy data between tecovirimat and brincidofovir. And vaccinia immunoglobulin had some benefit in case reports for disseminated vaccinia. So, as I've said a few times, when managing a patient with Mpox, the most important thing to remember is that most patients recover fully, even without medical countermeasures, primarily needing supportive care. Patients with severe outcomes are limited mainly to those who are significantly immunocompromised or other risk factors that we'll discuss. However, it's important to note that Mpox can cause considerable morbidity and can also cause considerable pain. These lesions are painful, can become infected, and supportive care is really essential to help patients manage their symptoms during recovery. Symptom management focuses primarily on supportive care, pain relief, infection prevention, and facilitating healing. Topical agents like lidocaine gels can provide local pain relief, while anti-inflammatory medications like NSAIDs can help manage inflammation and pain. For more severe pain, prescription options like gabapentin and opioids have also been considered and used widely. And they've also done a lot around starting antibiotics, either topical or oral, early when infection is suspected. While supportive care is sufficient for most patients with Mpox, some may require medical countermeasures. The currently available options include vaccinia immunoglobulin, tecovirimat, cidofovir, brincidofovir, and trifluridine, and we'll talk about each along with indications for use. For people who may need medical countermeasures, there's really three main categories. Those with severe disease, think about those requiring hospitalization or surgical intervention, or presenting with life-threatening symptoms. Those patients at risk of severe disease. This includes persons who are immunocompromised, those with serious underlying skin conditions, pregnant persons, and pediatric patients, as well as those participating in clinical trials. The CDC has published a really nice MWR that has a flowchart, which provides interim clinical treatment guidelines for severe Mpox and offers further direction on management approaches. The first point I want to highlight is that given the similarities in the viral life cycle, treatment differences between clade 1 and clade 2 Mpox are not necessarily expected. We're hopeful that the things we are talking about today as medical countermeasures would work for either clade 1 or clade 2, given the similarities in viral life cycle. So when I'm talking about Mpox treatment today, I am talking about the same treatment options for both clades. We'll start with tecovirimat, the primary treatment used during the Mpox outbreak. Tecovirimat was approved via the animal rule pathway, meaning that they had very limited human data on this medication before the start of the outbreak. To gain approval, efficacy was demonstrated mainly through animal studies, while human safety data came from a study involving 359 healthy individuals. I will say that at the for the first question we had earlier, 40% of people thought that there was a human randomized controlled trial of tecovirimat, and we do not have, or that showed tecovirimat efficacy, and we do not have one yet that we'll talk about in just one second. So in the US, tecovirimat was widely used during the outbreak, which is, I think, why so many people think that we have good data supporting its use. Almost 7,200 patients were treated, and the CDC received outcome forms for about 22% of them. Most received treatment for sensitive anatomical areas, so groin and rectal infection, as well as pain. Out of those, only 132 severe adverse events were reported, 40 deaths that were not attributed to tecovirimat, as well as some headache, nausea, vomiting, elevated LFTs, and urticaria. So out of all these patients, one of the things we can say is that the data really suggests that tecovirimat was safe with very few adverse events attributed to the drug itself. However, the biggest question that remains is, even if it's safe, does tecovirimat work? You know, our observational data was mixed, with some studies suggesting a benefit and some studies suggesting not a benefit. However, observational data is really challenging to interpret for a self-limited disease like Mpox. What we really need are randomized controlled trials to determine tecovirimat's effectiveness. And the first one of those that's complete is the POM-007 trial in the Democratic Republic of the Congo, or DRC, which studied the effect of tecovirimat on clade 1 Mpox. While there's not yet a publication, these findings were shared at ID Week. This was a randomized controlled trial involving patients diagnosed with Mpox. They were hospitalized for 14 days, received nutritional support and regular sampling, as well as PK analysis. The primary outcome was to assess whether tecovirimat improved time to lesion resolution, and secondary outcomes included time to resolution based on early or late treatment initiation, decided as 7 days, virologic outcomes at 14 days, and analysis of subgroups by age and disease severity. They rapidly were able to enroll 597 participants with a median age of 15.9. 64% of all enrolled participants were pediatric age. About half were female sex at birth. Mean days from symptom onset was about 5.9. The mean lesion count was 487, and only about 0.7% were persons living with HIV. And top-line results were released in a press release, indicated that tecovirimat did not improve clade 1 Mpox resolution. And when you can see from the Kaplan-Meier curve here, there was no statistically significant difference in time to lesion resolution. I'll also highlight some of the secondary analysis. There was no difference in lesion resolution when stratified from greater or less than 7 days from symptom onset, or virologic outcomes at day 14. Overall, I think as of now, it's pretty clear that at least in the POM-007 study, tecovirimat did not show a benefit in treating clade 1 Mpox. The limited efficacy of tecovirimat has raised questions about dosing. Tecovirimat's dosing was initially derived from non-human primate models and validated in healthy individuals. So there really was very little PK data or pharmacokinetic data for patients with Mpox before this outbreak. An Italian study investigated the steady-state PK in 14 hospitalized patients with severe Mpox, revealing significant differences between individuals with and without HIV. Similarly, early findings from the study of tecovirimat for Mpox, or STOMP study, also noted PK variations among patients with severe Mpox. While all these concentrations were above the in vitro 90% MIC, they could still be clinically relevant for patients, particularly those with more severe disease or compromised immunity. However, when they looked at the POM-007 data, they saw no difference in days to resolution by concentration, suggesting that it's not clear that dosing is the problem. A second question is, could it be resistance? And there is growing evidence of tecovirimat resistance in multiple case reports and observational studies. One notable CDC study, one of the larger case series, looked at the Mpox F13L gene, where single amino acid changes are known to cause resistance. Using both genotypic and phenotypic assays, they looked at 96 isolates from 46 patients. All were severely immunocompromised, and all had received multiple courses of tecovirimat, resulting in a resistant phenotype. One interesting thing they saw here is that some of these mutations, even the same mutation, in patients without tecovirimat exposure, typically remained phenotypically sensitive. It suggested that resistance may have been driven by selective pressure from repeated tecovirimat exposure, especially in immunocompromised patients. However, as we'll see, that's not always the case. We're now seeing that tecovirimat resistance isn't limited to individuals who've received the drug, as recent findings in 2 different studies show the possibility of transmitted resistance. In Southern California, the California Genomic Surveillance Network identified 11 Mpox cases with the same tecovirimat resistance associated mutation. Phenotypic testing confirmed resistance in 10 of these patients, none of whom had prior tecovirimat exposure. 7 of these cases were actually epidemically linked to a festival, indicating the potential of person-to-person transmission. Additionally, the CDC recently reported 18 Mpox cases across 5 states with a unique combination of F13 mutations, also all in individuals without tecovirimat exposure. Phenotypic testing was able to confirm resistance in 7 of these 18 cases, and this cluster was genetically distinct from the California cases, suggesting the independent emergence of multiple resistant strains that may be being transmitted. This really highlights the importance of more data. What we know for sure is that more data on tecovirimat is essential, and I do want to highlight the STOMP study led by the ACTG. In full disclosure, both Dr. Currier and I are heavily involved in this study. And the STOMP trial is focused on clade 2 Mpox. Compared to POM, it is primarily adults, while POM was 64% pediatric, with a different baseline health status and a real focus on sequencing and looking at resistance analysis. Just for people who may not be aware, both in-person and fully remote options are available for enrollment, and so this study is open to anybody in the United States, and we have international sites as well. If you encounter a patient with Mpox, please consider referring them to the study so we can learn more to address some of these considerable questions. Given the uncertainty around tecovirimat's effectiveness and the potential severity of Mpox in persons who are immunocompromised, we really do need more treatment options. Vaccinia immunoglobulin is licensed for treating complications from vaccinia vaccination. It's available for Mpox through a CDC expanded access IND. While there's no proven benefit specifically for Mpox, it has been shown anecdotally to be effective in treating progressive vaccinia, another orthopox virus. However, due to its high cost and limited supply, it's generally reserved for severe cases in immunocompromised patients, especially those who may struggle to mount a strong antibody response. Next up are antiviral medications, starting with trifluridine. Trifluridine eye drops are an option for patients with ocular Mpox, although the data is very limited. These drops are FDA approved for herpes eye infections and are thought to have activity against orthopox viruses as well, especially in vitro. The CDC does recommend considering trifluridine in cases of ocular Mpox, and there are a lot of anecdotal case reports of improvement after starting trifluridine. Next up are cidofovir and brincidofovir. These are very similar medications. Cidofovir is FDA approved for CMV retinitis, but has been known to cause renal toxicity, and so its utility is limited significantly by that fact. Brincidofovir is a very similar drug. It has a different side chain that's thought to reduce renal toxicity. It's a prodrug that's thought to reduce renal toxicity. Brincidofovir is approved through the animal rule for smallpox and is available through an FDA EIND. Just like with tecovirimat, our efficacy data is from non-human primate studies. However, in this case, we have a little bit more safety data. Safety data is from trials from adenovirus and CMV that were not necessarily effective, but demonstrated rates of diarrhea of around 5%, hepatitis of 5 to 11%, and some other side effects like embryo-fetal toxicity, spermatogonia, maturation depletion, and potential mutagenesis, really making it a little bit worrisome to use these drugs. With that said, they are being recommended in severe cases of Mpox, particularly among those people we saw earlier are most likely to have ongoing replication. And brincidofovir is not necessarily recommended to be used alone. The data suggests that combining brincidofovir and tecovirimat results in synergy against orthopox viruses. It showed that both drugs together actually enhance the antiviral effects beyond what either drug achieves alone, as an appealing therapeutic option. And so in general, we use brincidofovir for severe disease not responding to tecovirimat. We add it. For patients who are unable to take tecovirimat, it may be considered as monotherapy. And we consider adding it to tecovirimat for patients at risk of severe Mpox early on. In fact, the CDC recommends starting it as early as possible in patients with low CD4 counts or who are immunocompromised for other reasons like solid organ transplant yeah, or receiving chemotherapy. Although systemic cidofovir has rarely been used, topical and intralesional cidofovir have been used with varied outcomes. There was a really recent case report that I want to highlight. It was a gentleman in his 50s with advanced HIV and refractory Mpox. Over 3.5 months, he received multiple courses of multiple medical countermeasures with no sustained response. They gave him intralesional cidofovir weekly for 3 weeks, leading to the dramatic improvements shown in these images. The patient actually continued to experience resolution without recurrence 2 months later, despite minimal immune recovery and inconsistent outpatient ART adherence. And so intralesional cidofovir is another option for patients with severe disease not responding to other medical countermeasures. That covers our currently available options, but I do want to mention some emerging treatments that are in earlier stages of development. For example, monoclonal antibodies against Mpox are currently being tested in animal trials and could offer new therapeutic options in the future. And a repurposing of an old drug, adefovir, has shown up in drug repurposing studies a couple of times now, although it's still pending even animal data to confirm its efficacy. But these are two things that are out there and you may hear about. So sadly, while we've not learned enough about treatment, we did learn that tecovirimat is safe. Tecovirimat selects for resistance in patients with prolonged infections, and that we may see transmitted resistance to tecovirimat. We also learned that tecovirimat was not effective in POM-007. And we really need clinical trials to know if tecovirimat works against clade 2, if brincidofovir is effective against Mpox, does VIGIV work, and what is the best treatment or treatments or combination of treatments for our patients who are immunocompromised. Finally, our last section is on prevention and vaccination. The start of the outbreak, smallpox vaccine for Mpox was thought to be about 85% effective. And we did have an approved vaccine for Mpox in the modified Vaccinia Ankara vaccine, or MVA vaccine, that was available through the Strategic National Stockpile. We'll start with what we learned about preventing Mpox through behavioral change. This is the group most affected by Mpox was gay, bisexual, and other men who have sex with men. And after enduring COVID, like all of us, they then faced yet another major outbreak. And at the start, many adjusted their behaviors to reduce Mpox exposures. While behavior change isn't meant to be permanent, it can serve as a bridge to vaccination, a key protective measure. And emerging UK evidence really suggests that this is what happened. The self-protective behavior combined with vaccination really played a critical role in controlling the outbreak in the most affected communities. As we said, behavioral change is not permanent, but a bridge to vaccination. And so let's talk about vaccination. The Mpox vaccine can be used for both post-exposure prophylaxis and pre-exposure prophylaxis. For PEP, the vaccine should be given as soon as possible after exposure. While there's no human efficacy data, animal studies do suggest that vaccination within 4 days may prevent disease and up to 14 days may reduce symptoms. For pre-exposure prophylaxis, it has been historically recommended for lab workers and public health responders, but during this outbreak has been expanded to include epidemiological risk groups as well. I'll start with PEP because we don't have a lot of data. And our data on PEP effectiveness is limited. There's no randomized control trial in humans, but there is an observational study that tried to provide some insights by emulating a sequence of nested target randomized trials, starting each day post-exposure. This study conducted 2 analyses, a traditional multivariable regression and the target emulation trial. And among 594 individuals, the adjusted PEP effectiveness was 78% in the traditional analysis, but dropped to 19% with an extremely wide confidence interval in the target trial emulation. And so our data on PEP effectiveness remains extremely limited and honestly inconclusive. When we compare that to prevention or vaccine effectiveness for prevention, it's very different. This chart shows that vaccination, at least in observational studies, reduced infection with one dose efficacy from 36 to 86% and two dose effectiveness from 66 to 89%. We don't have a randomized control, and I don't think we will right now, given that the amount of observational data really leads to a lack of equipoise. While we don't know the exact number, it's pretty clear that vaccine does help prevent infection. But as always, vaccine doesn't just prevent infection, it also mitigates disease severity. There was one study that looked at 37 patients with prior infection, with either a previous infection or complete vaccination. And the results showed that those individuals, if they had infection again, had less severe disease with fewer confluent lesions, diminished mucosal involvement, reduced analgesia requirements, and fewer admissions. And additionally, a study out of California showed a reduction in hospitalization rates following vaccination. So it's clear that both vaccination and prior infection provide a level of protection against at least severe Mpox. Vaccination impacts not only severity, but also the presentation of Mpox. This study out of a Seattle sexual health clinic, researchers actually conducted Mpox PCRs on testing of rectal and pharyngeal specimens from both symptomatic and asymptomatic patients from May 2022 to May 2023. They found that only 1% or so of patients tested had asymptomatic or subclinical Mpox, suggesting that asymptomatic Mpox is rare. However, patients who were vaccinated were much more likely to have asymptomatic disease. People with one dose of MVA vaccine were 4.4 times more likely, and patients with two doses were 11.9 times more likely to have asymptomatic versus symptomatic Mpox, really highlighting yet another benefit of vaccination. Currently, the ACIP recommends who should be vaccinated, and they recommend the two-dose series for people aged 18 and older, gay, bisexual, and other men who have sex with men, transgender and non-binary people, who in the past 6 months have had one of the following: a new diagnosis of an STI, more than one sex partner, sex at a commercial venue, sex in association with a large public event in a geographic area where Mpox transmission is occurring, sexual partners of persons with the risk described above, and persons who anticipate experiencing any of the above. There are some special circumstances we get asked a lot. Previous smallpox vaccination probably does provide some protection, but it may not be lifelong. And they do recommend that vaccination be given to eligible people who were previously vaccinated against smallpox, unless somehow that vaccine was in the prior 3 years. Pregnancy is not a contraindication to MVA vaccination. Individuals previously infected with Mpox do not require vaccination, as the immune response to Mpox infection is quite robust, and it confers additional immune protection above that of vaccination. And vaccination is not recommended routinely for healthcare workers, given the effectiveness of routine infection prevention and control practices. There's been a lot of question recently about the duration of protection. Early studies indicate a decline in neutralizing antibodies over time, and previous research has suggested that maybe titers against vaccinia correlate with neutralization. However, many more studies are needed to link what antibody levels are actually needed to protect against Mpox and track vaccine titers over a longer period. We really don't know how long protection lasts, and so the fact is that we can't follow antibody titers to just answer that question. There are some things we know about sustained vaccine effectiveness. Non-human primate studies with clade 1 virus showed 2.7 and 3-year effectiveness regardless of antibody levels. Additionally, unpublished data among healthcare workers suggest protection for at least 5 years after the two-dose series. And to me, the most convincing data is there's no epidemiological evidence of waning immunity. Since October of last year, we've seen a pretty stable case count, despite the fact that most people were vaccinated around the same period of time in that fall of 2022. You would think that if vaccination protection was waning, we would see a slow increase in the number of cases per month and not this steady state. So another question is, will vaccines work against clade 1 and clade 2 disease? Mpox vaccine is actually against vaccinia, not Mpox, and is supposed to be a pan-orthopox vaccine. There's a very high degree of sequence similarity between orthopox viruses and a wide breadth of antibodies targeting multiple membrane structural proteins, All this to say that we expect that the same vaccine will work against clade 1 and clade 2. I will just say, as we wrap this up, I get the question a lot, why do we see this ongoing outbreak in the DRC if vaccines are so effective? And the answer is because we didn't send them vaccines. It's possible that this could have been mitigated if vaccines were accessible in the DRC, where they were needed the most. Unfortunately, the WHO recently pre-qualified the Jynneos vaccine, with the first doses arriving relatively recently. This really serves as a crucial reminder that all health is global, and what happens elsewhere can ultimately affect us all here. And so we learned that self-protective behavioral changes can be highly effective for a period of time, and that vaccination is highly effective in preventing or attenuating Mpox. We still need to learn more about how long protection lasts after vaccination. We need to know how long protection lasts after infection, and does PEP with MVA work? And we will wrap it up here, but the 2022 Mpox outbreak was different. It changed a lot about what we had previously known about the epidemiology, transmission, and presentation of Mpox. We learned a lot about rapid person-to-person spread through sexual networks, severe disease in immunocompromised patients, pre-symptomatic and asymptomatic live virus identified, tecovirimat not effective in its first randomized controlled trial. It's that it's safe, but can lead to transmitted phenotypic resistance, that MVA vaccine is effective for preventing or attenuating disease. The clade 2 Mpox outbreak is not over. It did spread rapidly and cases are still occurring. The clade 1 public health emergency of international concern is ongoing. Managing Mpox will require a global effort, and we still need to know a lot more. And I'll thank everybody who made this possible, and we'll move on to the post-test now.
All right, we wait for the answers here. Jason, that was fantastic. Really a tour de force of updates about Mpox. Okay, we still have 21% who think that tecovirimat was shown to be effective. And I think that I want to maybe in the Q&A focus on this point a little bit, that the PALM study did not demonstrate efficacy in this, but this was in clade 1. So could you talk a little bit more about why you think it may have failed? What are some of the clinical differences about the presentation and the populations in the PALM 07 study and what's being studied in STOMP? I think it's important for people to understand why other studies are still ongoing despite this failure. And I know you had a lot to get through, so let's drill into that a little more.
Absolutely. So we can talk about that for a second right now. I think a couple of things. One is it was clade 1 disease versus clade 2 disease. So, we're studying clade 2 disease in STOMP, and clade 1 was there. The patient population is very different. They were 64% pediatric. Ours is almost entirely adult. Actually, ours is entirely adult in the randomized arm. They also have different baseline health and baseline nutritional status, and I think that may play an important role. And then the other thing is we're looking very closely at dosing and other things like that may help us better understand why the drug didn't work, and things that can be adjusted for future studies to see whether or not this drug works. There's also the possibility, as we've learned in other viral illnesses, that monotherapy is maybe not enough, and maybe you need combination therapy. And so really exploring all the different potential avenues and explanations for why the drug didn't work when it looks like it's so promising in vitro studies.
Yeah, and then maybe to add to that, the clinical presentation and features of the clade 1 disease with so many more lesions. I don't know if you know off the top of your head, but the average number of lesions in participants in that study was extraordinarily high and much greater than what we're seeing, right?
Yeah, the median lesion count was 487.
487. Imagine counting all those.
I was thinking the same thing when they first showed this data, which is much higher here, which ours was somewhere between 10 and 20. I don't remember off the top of my head, but it was in that vicinity. So certainly much lower lesion count that we're seeing.
Yeah, who can count that many? Okay, so I think that really does kind of highlight that. And we don't yet know whether resistance was identified in the PALMA 07 study. I'm sure that that they're looking into that, but my understanding is we don't have that information. Oh, we have a second post-test question. Sorry, I jumped right in there.
That's okay. And that is the correct answer. Gay, bisexual, and other men who have sex with men. 94% got that right. For persons traveling to the Democratic Republic of the Congo, they're only recommended to be vaccinated if they're intending to engage in sexual activity or other activities that would be expected to put them at risk for acquiring Mpox. So just routine travel there does not require vaccination.
Okay, now we can move into the Q&A, which I already started. One of the questions is about the clade 1A in the UK. Are they all associated with a link to Africa DRC, or yeah, are they just spontaneously showing up?
Yeah. So all 4 in the UK were from a single household with an exposure.
Okay, good.
So it did not appear to be they did not identify it in unrelated people, which is always what you worry about in these situations. It was all in a single household.
Okay, great. And then what role might infection-acquired immunity to Mpox from clade 2 be playing in preventing a subsequent 1B outbreak in the US?
Yeah, I think it'll play a large role. We still see cases, yes, we showed numerous times, 50 or so cases a month, meaning that we still know it's around, but the combination of vaccination and protection from prior infection is probably what's keeping it from being a more widespread outbreak. We would expect that the immune response, both to vaccination and prior infection, would protect these same individuals from clade 1 as well. And so we would not expect that we'd see magically a really large outbreak of clade 1, because again, we know clade 2 is around and we're not seeing it there.
Okay, great. And then what's the proposed mode of transmission in the asymptomatic or pre-symptomatic spread? What do you think's going on there?
Yeah, if I had to suspect, I'd suspect it's in body fluids, whether that's in mouths and saliva, in semen, or in rectal fluids. I would suspect there, but we don't have great data yet on exactly what it is, but I know there are studies ongoing to try to look at that.
Okay. There's another question about vaccination and asymptomatic disease. What might we imagine about how transmissible asymptomatic infection might be, and how the lack of symptoms might prevent people from engaging in behavior to prevent onward transmission?
Yeah, I think this is one of the both important and unanswered questions that we saw in the data. The data from there was it was a PCR test. And so from a PCR test, we know that the virus was detected, but we don't even know if it's live virus that is transmissible. I think the next steps would really be to do a live virus study in a similar way, try to understand if these people with asymptomatic disease actually have live virus, and then try to understand a little bit better how likely that virus is to transmit to other people. And I think those are really hard studies to do, but I think they're really important because I would suspect that asymptomatic or pre-symptomatic people are contributing because people aren't engaging in behavior change if they don't know they need to.
Okay, good. And then there's a question in the last 3 to 6 months of every participant, this person, Robin, is enrolling in the STOMP study, have been previously vaccinated 2 years ago. What studies are currently being done to determine if and when we need to be given boosters? And thank you for enrolling in the STOMP study. As Jason said, this is what we really need to understand if the tecovirimat is going to be effective.
Yeah. Robin, I don't know the full extent of the vaccination research ongoing. I know there are a lot of people looking at antibody levels. There are some observational cohorts that may be able to help us with this. But I think the most important thing is to understand if we should be giving boosters is really the epi data. If we start to see the epi data creep up and all of these patients are vaccinated, I think that would be a strong indication that we need to look closer and see whether we need to be giving boosters. With the data being just so stable, it seems that we haven't hit that point yet. And obviously, I think we need to watch closely to make sure that when we hit that point, we're able to pivot and change what we're doing and not wait till it's too late.
Yeah, there's another question about that, given the recent studies show that the two-dose Jynneos-induced antibody response is short-lived,
Yeah.
yet CDC currently does not recommend boosters. And are there certain high-risk previously vaccinated people that you might consider recommending a booster, and when?
So in general, no. I think, the healthcare worker data that's not published, but that the CDC has is really compelling, as well as the non-human primate data. I think the one group that I think about a lot, though, are similar to like we do for other vaccinations, people with HIV who had low CD4 counts at the time of their first vaccinations, but then reconstituted. I think there could be a benefit in those groups, and we've done that in other vaccinations as well, but we don't have any data to support that. But that's the one group I think about doing it in.
And then there's a question about whether someone who's already infected could basically become asymptomatic and continue to transmit. Is there sort of a carrier state, a potential source of future transmission?
When I think of latent infection, I think of like long-term carrying, and I don't think that's very likely. We've not seen that with other orthopox viruses, so I'd say probably not. I will say that patients can become asymptomatically infected, as we talked about earlier, and for at least a short period of time could potentially be contributing to ongoing transmission.
Okay, a question from Orbit about whether he thinks it would be a good idea for the ACTG to do a longitudinal study to see the durability of the Mpox vaccine efficacy.
I think that might be a better question for you.
Yeah, I mean, I think this is I think that this is a question for the NIH, NIAID, and DMID. The ACTG was brought in to do this study and rapidly got it going. But I think these are important questions that do need to be answered. And the right place for that is probably beyond my purview. But I do want to just make a pitch about the STOMP study. Many of you have referred people, but if you see the number of cases that are still occurring every week, around 50, we could finish this study in 2 months if we just got a higher proportion of people enrolled. And as Jason mentioned, you can live anywhere in the US and enroll in the study remotely, and the drug is sent directly to the participant. All the provider needs to do is to connect the person with the hotline, and they'll be referred to a site. So it's such important data that we just need people to be aware of that. And it will make it easier for the provider if the participant is in a study as well for getting, they will be randomized, but I think given the PALMA-07 data, we really need to demonstrate whether this drug works, and hopefully we'll have the opportunity to look at the combination with brincidofovir in the near future.
We also, for people in Canada, have a shout out for the Platinum Canada trial down there, recruiting at St. Michael's Hospital in Toronto. So for those people who are in Canada, the Platinum Canada trial is a very similar trial, also ongoing.
So important question. There was something about the PALM study potentially showing a benefit in those who were treated early and those with severe disease, a subgroup analyses. Do you want to say more about that? Probably more slicing and dicing is being done, but any comments from the data that you've seen?
I saw that in the press release. They didn't present any of that data at ID Week. So I'm not part of the PALM study, so it's hard to know exactly what that looks like, but they didn't present it at ID Week, so it's hard. There's not much I can say. Sorry.
There should be a publication coming out at some point soon.
I would
right?
think so.
Yeah, sure they're hard at work on that. They did, I think, really want to give huge kudos to the team who did the PALMA-07 study, completed the follow-up, and presented the results and the press release in really record time, which is so important. And there's a question about, is there, from Ben Ryan, are the updates on potentially combining the STOMP data with the European study or Unity trial? And though there have been discussions about that, At this point, the plan is to complete the STOMP trial as designed and Unity, and then potentially combine afterwards. Since there's such an urgent need to be absolutely sure about whether there's a benefit, the thinking is it will be better to look at the individual studies rather than stopping them early to do that. One last question here. Did eradication of smallpox and subsequent ending of smallpox vaccination set the stage for expanding Mpox?
Maybe. I think it's certainly possible. I think, trying to understand, like most things, it's probably multifactorial. Larger urban areas, more urban areas certainly can lead to greater spread, greater international travel, and other things open up the door. But certainly the eradication of smallpox and the ending probably at least contributed in some way to people who were both more susceptible and had no baseline protection at all.
Okay, well, Jason, that was really fantastic, really wonderful questions from our very engaged audience today. I want to thank you for all these updates and everyone for participating. We have a couple more slides here, just to CME evaluations. They'll be emailed by 5 o'clock Pacific time. We do want to hear your feedback. We have other, IAS-USA has other things coming, and Jason's going to be doing a podcast with Mike Sag, which is a question answer. So that will be coming up soon. And this webinar will be available on demand through February of 2025. And I'm hoping that as we get more information, we can get Jason back again in the future. In November 22nd, and just another week and a half from now, David Wiles will be presenting on where we are with hepatitis C elimination, moderated by Dr. Kara Chu. And then in partnership with HIV-MA and IDSA, with the release of the new 2024 primary care guidelines for people living with HIV on December 4th, Melanie Thompson is going to do a presentation. Also, the annual IAS-USA DC virtual course, an update on HIV medicine and emerging challenges, is coming on December 3rd. There's a QR code here on the screen and the list of speakers on the left. It's really a great group of faculty. You can listen to this virtually from 11 to 3:30. And then the Ryan White Conference happening next week in Louisville, Kentucky. So lots of programming available for folks, both virtually and in person. And don't forget CROI 2025 in March 9th to 12th in San Francisco. That is going to be here before we know it. So looking forward to that. And then a new programming on bacteriophages, biology, dynamics, and therapeutics. This will be next year in October. Save the date in Washington, D.C. Really emerging science of bacteriophages for therapeutics. And this will be really the first of this new conference series. And thank you today for participating today and for all of your great questions. And again, thanks to you so much, Jason, and to IAS-USA for putting this on. Take care.
Thanks, everybody.